This lecture is part of a series of lectures for a course entitled The Physics of Diagnostic Radiology. The first lecture, MRI Systems and Hardware, is broken down into 4 parts. Lecture 1, Part 1 covers an introduction to MRI. At the end of this module, you should be able to reach the following learning objectives: to explain what MRI is in a few sentences, to recall the basic exam requirements for MRI, to name the basic hardware requirements for MRI, to explain the importance of Faraday's law of induction to MRI, and finally, to list 3 or more advantages and disadvantages of MRI. We begin by asking the simple question, what is MRI? The M stands for magnetic. We use a large magnetic field, and in fact we need several different magnetic fields to generate a magnetic resonance imaging. We'll learn about these different fields through the course of the following lectures. MRI also takes advantage of a so-called resonance phenomena, where an excitation energy has to be on resonance with the underlying system. In this case, we use, as shown in orange on the right, radio frequency pulses to excite water molecules such that they can emanate electromagnetic radiation that can be received in a nearby coil. This reflects a classic excitation reception paradigm that could be contrasted to other imaging modalities. And finally, of course, the I stands for imaging. And for imaging, we can make pretty pictures which have substantial diagnostic utility and, of course, give us substantial insight to a variety of pathologies and can be used for research purposes as well. In a typical MRI exam setup, we see something like the following. A patient lies on a table, and the table can advance into the middle of the MRI scanner, sometimes called the bore. A technician or a nurse will place a coil anteriorly on the chest of the patient if the chest is to be examined during the course of the MRI exam. There are typically several or even a dozen different coils unique to the body part that will be examined. So we have head coils for examining the head, knee coils for examining knees, foot and ankle coils, and so forth. For a cardiac exam, it would proceed as follows, and we would give the patient earplugs to protect their hearing during the noisy MRI exam. And in fact, we will usually provide them with two-way communication headsets so that we can speak to them and they can hear us, and they can speak to us. If it's specifically a cardiovascular-related exam, the imaging needs to be synchronized to that patient's heart rate, and therefore we place ECG leads anteriorly on their chest. For many MRI exams, we'll use a contrast agent, and that contrast agent is used to highlight the location of the contrast agent, which typically resides in the blood pool, but is sometimes extravasated into tissues, like tumors or infarcts. The administration of a contrast agent typically requires a power injector, so that the amount of contrast agent injected can be controlled precisely and delivered slowly. And as a result of an overview image, as shown on the right-hand side, we can select different views, in this case of the heart, and obtain very interesting dynamic images of the heart during different cardiac phases. And this just provides a simple overview of a somewhat typical MRI exam setup. So what are the fundamental requirements for MRI with regards to sort of the physics and the engineering of these systems? Well, to begin with, we need an NMR active nuclei. For example, the proton, H1, in water. We also need magnetic fields, and in fact, as I mentioned earlier, we need several magnetic fields. We need a so-called main magnetic field, typically called B0, which, as we'll learn later, serves as a polarizer to prepare the spin system, that is, the water molecules, for imaging. In order to excite the polarized spin system, we need an RF system, frequently called the B1 system, and this system acts as the exciter. It emanates electromagnetic energy on resonance with a frequency of the precessing water molecules. If we're actually to perform an imaging experiment, then we will need gradients. Gradients generate magnetic field variations in the X direction, the Y direction, or the Z direction. They can be turned on independently or in combination, and they fundamentally underlie the concept of spatial encoding. That is, localizing the molecular activity of water to different locations within the body, such that we can excite the slice of interest, whether it's an axial slice, a coronal slice, or a transversal slice, or a sagittal slice. And finally, we will need a coil. And the coil acts as the receiver. The fundamental principle underlying the signal reception in NMR is simply Faraday's law of induction. On the bottom right-hand side here, we can see a time-varying magnetic field, that is a person moving a bar magnet back and forth, in proximity to a loop of wire, or a coil. You'll see as the magnet is moved back and forth that a magnetic field induces a current in that coil that's detected with the voltmeter on the bottom right. NMR operates on the same principle. That is, the water molecules that are processing at a very particular frequency are in fact behaving like small magnetic dipoles and therefore can induce a flux in a nearby coil according to Faraday's law of induction. And this principle fundamentally underlies our ability to detect and measure the NMR signal. And finally, we'll need computers. Computers are used for a variety of reasons. Obviously, we use them to generate the magnetic field pulses and gradients that we need to generate the image and excite the imaging plane in the first place, and then we subsequently need computers to both reconstruct the data and, of course, store the data. We can use this diagram as a way of understanding how we go from individual magnetic moments, that is, the hydrogen nucleus bound to things like water or other molecules, as we'll discuss later, and how those individual magnetic moments become organized to form so-called bulk magnetization when in the presence of a large external magnetic field that we call B0. There are many other steps that underlie the generation of a magnetic resonance image and explain for us how we go from individual magnetic moments all the way to images. For example, we need the B1 field to generate so-called transverse magnetization, which will vary as a function of time as it's precessing and decaying. We also need gradients to do the spatial encoding, and these magnetic field gradients transform our time-based signal into a space and time-based signal. As we mentioned previously, we'll need a coil, and that coil takes advantage of Faraday's law of induction to transform our spatially encoded magnetization into a voltage signal that can be recorded. That voltage signal undergoes a process of what we call phase-sensitive detection to generate a complex signal whereby we can detect the magnitude and phase of the transverse magnetization, which is useful for forming different kinds of magnetic resonance images. Finally, we need to know what gradients were applied during the spatial encoding process so that we can place our complex signal into the correct part of an array, which we call the K-space array. This generates a fundamentally complex frequency encoded signal that's used prior to forming the final magnetic resonance image. And lastly, we need to take those acquired K-space signals and put them through some underlying reconstruction process such that we can finally recover the image of the underlying object. In the most conventional forms of magnetic resonance imaging, this is simply done with a Fourier transform, but much more advanced techniques are now available that use a variety of sophisticated algorithms. We now discuss several MRI advantages and disadvantages. First, the MRI advantages. One of the hallmark advantages of MRI is so-called soft tissue contrast, the ability to well distinguish different soft tissues within the body. We can see here, zooming in, several axial images through the head, and remarkably notice that the image contrast within each of these images is strikingly different. What underlies the differences between these images is not the subject nor the anatomy or the disease, but rather changes to the way the MRI image is actually acquired. So you can see that on the far left-hand side, overall image contrast is relatively flat, whereas the images proceeding from left to right have different and increasing levels of contrast, in fact, sometimes inverted levels of contrast. And this is a really phenomenal and interesting aspect of MRI. That is, we can widely manipulate the underlying image contrast by changes to the way that we acquire the actual MR image. And this means that we can reveal differences in tissue structure, tissue pathology, and underlying tissue differences simply by looking at different kinds of MR images. This is relatively unique amongst medical imaging technologies, and certainly a strength of MR in general. Another advantage of MRI is the ability to acquire so-called arbitrary imaging planes. So here we see, over a variety of different anatomical territories, the ability to localize the imaging plane to specifically highlight the underlying anatomy. This has particular advantages for diagnostic radiologists that would like to see the anatomy from a unique and particular perspective, especially for organs that are oriented off-axis, as can be the case for the foot, the ankle, the knee, the head, or the abdominal organs. And so this comes across as a strength and an advantage of MR imaging in general. Another advantage of MR imaging is the fact that we don't need ionizing radiation. And while the health effects of ionizing radiation continue to be discussed and described in the scientific literature, suffice it to say that the fact that MR doesn't require ionizing radiation is a safety consideration that MR scientists like to promote. One of the last advantages that I'll discuss is the ability to image physiologic motion. You can see here in these dynamic and time-resolved magnetic resonance images our ability to see the underlying physiology of what's happening inside the human body. This has given us profound insight, in particular to cardiovascular function, and has emerging applications for imaging organs during motion, as well as imaging organs during interventional procedures. Another advantage, and one of the last advantages I'll discuss of magnetic resonance imaging, is so-called tissue characterization. We mentioned previously the ability to widely manipulate the underlying soft tissue contrast, but here we more specifically talk about using the ability to manipulate the image contrast to actually characterize underlying tissues. And it's relatively routine at this point to acquire T1, T2, T2 star, and proton-weighted images, all of which reflect differences in the underlying tissue. But we can also use MRI to give us perfusion information, diffusion information, and use contrast agents and the subsequent contrast enhancement to help better evaluate tumors or produce angiographic images. There's a wide array of flexibility in terms of what we can measure and acquire with magnetic resonance imaging to help us characterize tissues and understand their disease state, disease progression, and even regression in the presence of therapy. More advanced MR techniques will use so-called T1 and T2 mapping, something that measures the fundamental relaxation properties, T1 and T2, of a particular tissue. Other advanced techniques allow the ability to separate water from fat, such that we can do fat-water imaging and isolate fatty tissues that could be pathologic within organs, or in fact characterize the magnitude of iron that might be stored in an organ, whether it's iron overload in the liver or the heart or elsewhere. There are molecular approaches to using MR, which use so-called spectroscopic approaches to understand fundamental chemistry within living systems. We can use susceptibility-weighted imaging for identifying the presence of blood products and sometimes calcium. And there are non-contrast angiographic techniques as well. So MRI continues to undergo a lot of development in terms of its ability to accurately characterize various tissues and provide the diagnostic radiologists with the most useful information for treating, or rather interpreting, the disease of their patients. Now, of course, any imaging modality that has advantages will also have disadvantages. Amongst the major disadvantages for MRI, it's mostly related to safety. And all the various magnetic fields that are used in MRI have according safety considerations. And we'll discuss these when we get into the hardware components of this lecture series. But the main field, the B0 field, the radio frequency field, the B1 field, and the gradients can all contribute a range of different safety considerations. The B0 field is responsible for the so-called projectile effect, the fact that ferromagnetic objects can be attracted to the scanner, as shown here in this emergency cart, being stuck to the side of the MRI scanner. And one of the biggest safety considerations is the presence of ferromagnetic devices in the MRI scanner, which should be prohibited at all times. The radio frequency field, which again is used as the exciter, we'll learn later can lead to patient heating, and this is carefully regulated by the FDA so that we don't heat patients more than a minimum amount. And lastly, the gradients can lead to what's called peripheral nerve stimulation, a buzzing or tingling sensation, similar to when your hand or foot falls asleep, which can be felt transiently during an MRI exam. Now, all of these things are carefully monitored and controlled during the course of MRI exam, but an operator and a researcher has to always be very conscientious of these potential safety considerations. Other disadvantages of MRI include that the MRI exams themselves can be relatively slow compared to other imaging modalities. They may be expensive relative to other imaging modalities. In some sense, they're non-specific, That is, changes in image contrast do not tell you about a specific disease, but rather tell you about a general category of possibilities. The acquisition of MR images in generally is quite technically challenging, so it requires a great deal of user sophistication to acquire high-quality diagnostic MR imaging exams. And finally, MRI, of course, is not primary for all indications, nor should it be necessarily, but in some sense it's a disadvantage, as it was once hoped that MRI would become the one-stop shop for all clinical imaging. When it comes to examining patients or research subjects, it's important that they undergo a patient screening evaluation. The evaluation forms shown here allow us to capture any possible risk that a patient may pose that the MRI exam itself may pose to the patient during their exam procedure. And so these pages lead to a series of inquiries about the presence or absence of certain implanted devices, a previous history of allergic reactions to contrast agents used in MR, or any other possible concern that may be a contraindication to that patient undergoing an MRI exam. So the patients and the personnel who operate in the MRI environment need to undergo screening before an MRI exam, and this is critical. Is MRI a contraindication? Well, that depends on what the patient's prior history is. So on the left-hand side here, we can see an example checklist with potential contraindications to an MRI exam. But again, we have to know much more information to know if the proposed idea here is in fact a true contraindication, or if the exam can be procured safely. So lots of different implanted devices are available nowadays, and patients presenting in clinical settings could have any or many of these implanted devices. So it's important to understand the material composition of these devices in general, and then to specifically know the exact device that a patient may or may not have implanted, so that it can be determined whether or not that specific device presents a risk. Fortunately, on the right-hand side is a reference manual for magnetic resonance safety, specifically implants and devices, and it's an encyclopedic index of what's known about the safety of a very large range of devices. And typically this reference manual can be found at most MR scanners, so that the technicians can identify whether or not a patient has a high level of risk prior to an MRI exam. It's also important to recognize what the various safety designations are in MR, because sometimes the language is confusing, in part because MRI compatible gets used in the colloquial sense all the time, but that's not in fact an FDA-approved term. The three terms the FDA actually approves of use include MR safe, that is an item that possesses no known hazard in an MR environment. So these are things like plastic petri dishes and bed sheets and linens and earplugs and these kinds of things. It's possible that a device could obtain MR conditional labeling, and that is to state that an item has been demonstrated to pose no known hazards in a specified MR environment with specified conditions of use. And so the bottom line here is that some devices can be brought into an MR environment, but only if the MR system is operated in a specific way, which in some sense limits the MR performance so that the exam can be procured safely while a patient has a particular MR conditional implant. And finally, the FDA recognizes MR unsafe labeling. That is, an item that is known to pose hazards in all MR environments. And an example of that would be something like a floor buffer. And so MR unsafe stickers are frequently found in the MR environment, so that it's easy to identify that a piece of equipment should never be brought into the MR environment. MRI is also expensive. The systems themselves are expensive to purchase, costing somewhere between $1 million and $3 million per unit, sometimes more. They're also expensive to site. Building the MRI suite to accommodate an MRI scanner in a clinical environment is not expensive and can easily cost $500,000, $1 million, or even more. The systems themselves are highly engineered systems that are carefully calibrated and require regular maintenance, and a maintenance or a service contract will typically cost something like $100,000 per year. Now, if there's an upside to MRI being expensive, it's that the operational cost or the charge costs for running an MRI system are typically on the order of $500 to $1,000 in an hour, and that's to cover the fixed purchasing costs, the annual maintenance costs, and of course the interpretation through a clinical radiologist. MRI is also technically challenging. There are numerous scan parameters that are dependent upon the underlying clinical question. We have to make decisions about whether to acquire the images using what's called a spin echo or a gradient echo sequence. We have to select numerous imaging parameters, the repetition time, TR, the echo time, TE, the inversion time, TI, or the underlying flip angle. Oftentimes these things are saved as digital protocols on an MR scanner, but in a typical clinical environment, there will be hundreds of these protocols for hundreds of different clinical indications. Oftentimes patients need to undergo physiologic monitoring, be it ECG monitoring, respiration monitoring, blood pressure monitoring, and it's possible that patients may undergo general anesthesia or sedation depending on the quality of their life and their ability to follow directions during an MR exam. MRI exams frequently require breath holding. So if we're examining the abdomen and the chest, which are going to move, of course, during regular respiration, we might get a clearer and more sharp image if the patient can hold their breath for brief periods of time, maybe 10 to 20 seconds. Oftentimes we'll use contrast agents, and that requires using a needle into the antecubital vein to inject the contrast agent, loading the contrast injector, programming the contrast pump so that it uses the right amount of contrast agent at the correct rate. And all these things add to the overall technical complexity of an MR exam. We also have to choose coils, and while that's not terribly complicated, it adds to the procedural complexity of adjusting and setting up anterior arrays that pick up imaging information from the chest or the abdomen or the pelvis or the head or the neck. All of these different anatomical territories just require a little bit of fine-tuning. And lastly, the procedure of anatomic localization and actually acquiring all the images requires a good deal of sophistication. You have to know your cross-sectional anatomy quite well in order to be able to obtain images of arbitrary imaging locations that will be most useful to the diagnostic radiologist waiting for the images downstream.